Our next speaker is from the UK, Dr. Damian Griffin. He's going to tell us today about the prevalence and definition of FAI. Damian has been focusing on hip arthroscopy, treatment of FAI in athletes and non-athletes in ORIC, and he's also very interested in evidence-based medicine and is conducting great studies in the UK.
Thank you very much indeed, Mark, and thank you again to Per and the organisers for inviting me. I'm going to switch this on. I'm going to talk a little bit about the definition and prevalence of femoroacetabular impingement. Now, we've mentioned it a lot during this meeting, but so far there hasn't been too much precision about what we really mean. I come from Warwick, as Mark said. It's in the middle of the UK. I used to think that we had a really spectacular hospital. This is a more or less brand new hospital that's been built with public money in England until I came here. And now I really want to know who your architect is. Now, femoroacetabular impingement is a problem in which the ball and the socket don't fit. That's simplistic, but it's a good place to start. If we take a CT scan of a patient's pelvis with the two hips, and I convert that into a diagram, here the orange is bone, the blue is cartilage, and the black is the labrum. Now let's just look at the right hip for a moment. Now this is a normal hip, a normal shaped hip. This hip can move into internal rotation and flexion without impingement. This hip is a cam-shaped hip, and it's called a cam not because that's an acronym, but because this is a cam as in engineering. It's a non-spherical head to the hip. As this rotates, initially it pushes the labrum out of the way, especially in a young person with a flexible labrum. But then as it rotates further, this bulge of bone presses inside the acetabulum and applies pressure to the articular cartilage and especially to the junction between the labrum and the articular cartilage. And this is what leads to ongoing damage, eventually becoming delamination of that cartilage. Pincer-type impingement, the other commonly described variant of FAI, is different. In this case, the problem is on the acetabular side. The acetabular rim is prominent, so that as the hip rotates, the neck of the femur comes into contact with the labrum and squashes it, and repeated injury here leads to accumulating damage. Very often, scar tissue will then turn into bone, and that bone projects from the rim of the acetabulum, making the impingement even worse. And our hypothesis is that the impingement at the front there leads to levering of the femoral head, and that levering applies pressure to the articular cartilage at the back of the socket. And this seems to be a common scenario in women, and is perhaps a common cause of osteoarthritis in women, where we see clinically that at least a good proportion of women who have hip replacements primarily seem to have postero-inferior acetabular damage. And that contrasts with cam impingement being more common in men. So these are the two main categories that have been described, originally by Ganz and his group in Switzerland. Well, how can we define those? Well, in a sense, if we talk about a cam to start with, it's sort of obvious when you see it. Here's a bulge of bone at the head-neck junction, and you can see it at this operative view during open surgery, and you can see it on this CT scan with 3D reconstruction. But for epidemiological studies, we really need a way of defining it by measurement. Now, we might try and do it with plain X-rays. And here's an AP X-ray and the same patient in lateral. Now, on the AP X-ray, we're looking at profile at the 12 o'clock position. That's the top of the head-neck junction. On the lateral X-ray, if it's a well-positioned lateral X-ray, we're at the 3 o'clock position, anterior on the head-neck junction. Now, this is important because the alpha angle, originally described by Hubert Knotzley from Bern, was taken from oblique axial MRI scans, And those MRI scans, because they were an oblique axial scan, were showing the profile at the 3 o'clock position. So the alpha angle, as we heard a moment ago, measured within the sphere of the femoral head. From the center of the femoral head, a line is extended down the line of the femoral neck. And then the angle is subtended to another line that joins the bump to the spherical part of the head. This alpha angle really should be measured on an oblique axial scan at the 3 o'clock position. And that's what we should mean by an alpha angle. Now, many authors have tried to measure alpha angles in different positions. Some have only had access to AP X-rays, so they've described the alpha angle at the 12 o'clock position because that's all they had. Some have said, well, I can get a bigger alpha angle if I move around to somewhere between 12 o'clock and 3 o'clock. And we have good evidence of that now, that in most people with a cam shape, the maximum alpha angle subtended is at around about 1:30 between the 12 and 3 o'clock positions. So do be careful as you read the literature exactly where that angle is being measured and what sort of imaging was used. Because if you pull together all the epidemiological articles that have been produced, and this is many of them, you will see that they have used different definitions for what the alpha angle is, and different imaging techniques, and different positions on that clock face between 12 o'clock at the superior aspect and 3 o'clock at anterior. And what I've done here is to show you all the studies that I think are of reasonable quality, extended across. Each one's a bubble. And I've put in red there the proportion of the people they looked at who had an alpha angle that met their criterion for being abnormal. But I've also described there how they measured it, whether it was on a CT, whether it was on X-rays, or what position of the clock face it was at. Now, the patients at the top of the screen in the big red bubbles, those are people who were high-level athletes. The patients at the bottom in black are people who were not. But the mix of these patients is all quite different. And the ones who are most similar to the general population tend to be down here in the left-hand corner. So I'm afraid we come to the conclusion from this that the studies we have at the moment are too heterogeneous for us really to understand what an abnormal alpha angle is and what proportion of the population have that abnormal alpha angle. I can tell you that at the moment there's a sort of consensus around the idea that about 55 or 60 degrees is a threshold for abnormality, and that probably should be measured at 3 o'clock or at the 1:30 position or at the maximum position in that region. But there's controversy over which one of those to choose. And it seems to me that if you choose that sort of threshold, we could reasonably expect that around about 15% of the general population would have an abnormal alpha angle. That's very different, note, to those in the top right, athletes, where we know that using those definitions, the rates are much higher, up as high as 3/4 of men. So what about Pincer? Well, Pincer is actually much less well defined, even than what I've just said. So the classic definition of a Pincer abnormality is that the patient has a prominent acetabular rim measured on an AP radiograph using a lateral center edge angle. This is the subtended angle like that. More than 40 degrees is said to be abnormal. But actually there are other so-called signs of Pincer. The crossover sign, where the anterior rim of the acetabulum appears more lateral than the posterior rim. The ischial spine sign, where the whole acetabulum seems to be retroverted, so that the ischial spine is more prominent than usual. And we might measure that version of the acetabulum. So here on a CT scan, you can see the normal anteversion of the right hip. But on the left side, you can see that there's less anteversion. So this hip is relatively retroverted. But this is the whole acetabulum, not just a portion of the rim. So if we take those possible definitions and pull out studies that have described groups of patients using the same sort of mapping process, we end up with this. So you can see that athletes extend from a 4% pincer impingement rate to a nearly 0.75% pincer impingement rate, depending on which sign you use. Normal or non-athletic people, similarly, are extending from a very low rate up to half. So I would suggest that our definition of pincer impingement is so poor at the moment that we can really almost make no interpretation. If I had to come up with something, I'd say that it looks as if around about 10%, perhaps more in women, have something that we can identify as an abnormality. But I think we need to go a bit further than that, because those definitions don't include some of the things that clearly cause pincer-type impingement or impaction-type impingement. So if you've got, this is a young woman, a professional or semi-professional footballer. Her plain X-ray looks pretty normal, but if you do a CT scan, you can see that she's got nearly 20 degrees of femoral retrotorsion. And that means that as she internally rotates her leg, she will come into contact with the acetabular rim much more early than someone with normal morphology. And that's really a pincer type of impingement, but not defined by those studies we've looked at. Here's a patient with clear protrusio of the acetabulum. Protrusio and profunda, deep acetabulae. You can see it's obvious that this patient will impinge against the rims in a very limited range of movement. But that, again, is not defined by those criteria we've seen. And we've talked earlier on in this meeting about extra-articular impingement. If we're going to try and define all types of femoroacetabular impingement, we'd better talk about this as well. Here we have subspinous impingement and ischiofemoral impingement. These, we have no idea at all what the prevalence of them might be. So I think we've got quite a big list, and it's a growing list, of morphologies that lead to, or we think could lead to femoroacetabular impingement. But we only have a little bit of an idea of how to define these, and an even less an idea of what the prevalence in the normal or athletic population is. So if we take a population, and I'm using here the normal population rather than specifically athletic, it looks as if perhaps 10 or 20% of people have got something which on some imaging we could say was an impingement type morphology. What we really want to know is what happens to those people. Does that shape matter? We do have a little bit of evidence that having an abnormal shape can lead to cartilage damage, and we've talked about that a bit during this meeting. It's a degenerate scan showing a typical pattern of cartilage damage in cam impingement, and we know that in cross-sectional studies, having a larger cam seems to be associated with having more cartilage damage. And we have a little bit of information, and we heard about it the day before yesterday, that cam shapes in particular, not other types of FAI, but cam shapes may be associated with osteoarthritis. But the positive predictive value, that is to say, how confident can we be that you'll get arthritis if you've got a cam shape, is very low. And we have virtually no idea about other morphologies. And we even think that some morphologies might be protective. So morphology and symptoms is what we'd really like to know about. Does a patient who has an abnormal shape, and we've got a bit of an idea about how many of those there might be, have symptoms? Well, we do know that not everyone does. This is a study from Paul Bollet, patients who'd had operations on one of their hips. He looked at their other hip. Many of those hips had abnormal alpha angles, but he found that only about half of the patients with abnormal alpha angles had ever had any symptoms in those hips. So we know that having an alpha angle which is abnormal does not necessarily lead to symptoms. Not everyone with impingement morphology has symptoms. And in fact, most studies are now demonstrating that most of the people who have abnormal morphology do not have symptoms. So it looks as if it is possible that if you've got an impingement type morphology, you will develop impingement symptoms. And if you have both of those, I say you've got FAI syndrome, which is, I think, exactly what Joe was saying earlier on. FAI should be considered as a syndrome, not a radiographic diagnosis. You've only got it if you've got symptoms and signs and radiographic appearances which are consistent. So what makes it that some patients with impingement morphologies develop impingement symptoms and some don't? Well, we've heard about it already. It looks as if muscle control is very important. It looks as if what exercise you do and how much of it you do is important. and that might be why so many of our athletes suffer from these symptoms. Cumulative load is probably important because of cumulative damage to the cartilage and labrum. That may be associated with what you do, but also as you get older, your cumulative load increases. And it may well be that some people are more susceptible to cartilage injury or to experiencing pain. That may be a genetic influence upon this. And this gives us some potential strategies for intervention. Joe's talked about intervention with respect to muscle control, and later on we're going to talk about intervention with respect to surgery to change the morphology. And in fact, in Warwick and across the UK and in Australia, we're now doing a large randomised controlled trial to compare those two possible interventions, surgery compared with rehabilitation and retraining. So in conclusion, I think the definition of an abnormal morphology is controversial. Alpha angle is best established around 55 degrees, but be careful about where it's measured on with what radiology. Pincer, frankly, is a completely mixed bag, and I don't think that we can come to any meaningful conclusions until we break down Pincer into a number of subcategories. The prevalence of having some sort of abnormal morphology, if we looked in this room, probably about a fifth of you would have something that you might worry about. And I say that because so many of our patients come to us having had an X-ray or a scan and being worried about what they've been told. It's probably higher in athletes, particularly the cam shape. However, good news, prevalence of FAI syndrome symptoms is much lower. And I would advise you very strongly as a take-home message, don't diagnose FAI syndrome for imaging alone and try and discourage your radiologists from doing so. Thank you very much.